The next case is non-proliferative diabetic retinopathy progressing to proliferative diabetic retinopathy. And I think this case demonstrates how neuroretinal dysfunction can be picked up on ERG, sometimes before microvascular changes. So this is a 39-year-old type 1 diabetic who's had diabetes for 20 years. And his medications included Levemir, Novolog, Proventil, and Novolin. The best corrected visual acuity in the right eye was 20/20 and in the left eye 20/25. And treatment was started in both eyes for diabetic macular edema. And you can see in 2016, when he first presented to me, there was really quite a bit of edema, which is well demonstrated in the fluorescein angiogram. So you can see the circinate hard exudates with microangiopathy, intraretinal hemorrhages. There was some focal laser and quite a bit of edema. So I began treatment, and in 2017, you can see that I'm making progress. There are fewer hard exudates, and the edema looks a little bit better under control, but certainly he needed more treatment. In the left eye, there was non-proliferative diabetic retinopathy and diabetic macular edema, but it was not quite as severe as the left eye, as the right eye. So you can see in 2016 there were some hard exudates, and there was definitely DME with staining. You can also see that there was some laser. And in 2017, there's still edema, but we are making some progress. Some of the hard exudates had cleared. In 2017, I got a ERG, and you can see with the diabetic retinopathy assessment, it was abnormal at 24.3. So when I see this number, I know I have to keep on top of this patient, keep treating, and watch the patient carefully. And the implicit time and the amplitude was pretty much okay in both eyes. He did require quite a bit of treatment with both anti-VEGF and laser. In 2018, a year later, the ERG looked about the same. The diabetic retinopathy assessment was still high. The amplitude and the implicit time looked okay. The amplitude seemed a little bit better. We continued treatment. The ERG in 2019 looked a little different to me. When I compared the right eye to the left eye, I noticed that there was a change and that the implicit time was borderline normal, but now the amplitude in the left eye had dropped into the red zone. And I began to wonder about that. And I began to think, something going on? Is there a possible progression of the ischemia? And as we followed this patient, sure enough, we started to see NVE, which you can see in the supratemporal quadrant in this fluorescein angiogram. So the drop in amplitude and borderline implicit time were a red flag to watch for ischemia. And neuroretinal dysfunction can be picked up on the ERG and can be seen sometimes before the microvascular changes. What I found interesting is that the left eye had received fewer injections because there was less diabetic macular edema than the right. And as I think back, I'm wondering if the anti-VEGF injections that were given more frequently kept the right eye from advancing to proliferative disease. He has maintained good vision. His visual acuity is 20/32 in the right eye and 20/20 in the left. He's required a lot of treatment. With a full field ERG, diabetic retinopathy assessment was high, which alerted us to keep follow-up appointments on a tighter schedule. And the drop in amplitude in the left eye alerted us to watch for further ischemia like NVE and treat that eye more aggressively.